Perfect. Hi, I'm Eric. I'm a senior leader in our healthcare practice, doing a lot of work in seniors care and home care. And also just building off of the land acknowledgement, I think I'd like to recognize the wisdom and guidance of Indigenous elders who play really a vital role in terms of being knowledge keepers and storytellers. And I really hope in our conversation today that we can really carry their respectful teachings and ways into our discussions. And I think today's topic is one that collectively we need to get right and to address to ensure that we adopt a home first approach to enable Canadians to age in place, and if really they needed to age in care. And really making sure that we design our services to be senior friendly, whether that's in healthcare or our social programs. And at Deloitte, this is one of the areas that our healthcare practice really focuses on. And we have a lot of practitioners here today that are helping to increase access to seniors benefits, to help build long-term care homes, to really help design new models of care that are senior friendly and are providing care in the community. So really helping with all of that shift that we need, because we know we need more services for our seniors. And I think this lovely panel here today is going to talk about many of the solutions and ideas that they have. And I think just to say, we're thrilled to have you all here in person and online. And I would love to introduce Donna Duncan, our moderator for today. So Donna is the CEO of the Ontario Long-Term Care Association. She's super passionate about older adults. She's an advocate for mental health. And she's been leading a lot of system change in Ontario and across Canada. And she is also leading the largest long-term care association in Canada. She's a member of the board of directors of the Global Aging Network, and is a host of Coming of Age, a podcast that's really changing the conversation around how we do seniors care. So over to you, Donna. Thank you.
I'm going to start here. So good morning, everybody. And maybe I'm not going to do that. No, it's okay. Thanks. So good morning, everybody, and welcome. I have to say, this is the first time that our group has actually met in person. And in fact, our conversations were through Zoom over almost 3 years ago, started almost 3 years ago in the middle of the pandemic, and came out of a series of discussions when we realized we were all talking to each other as individuals in association to association, but we weren't actually talking as a group. And so we made the decision to come together and bring people together over a period of days. We had a number of facilitated days, thanks to Denny Nashman and the Potential Group and Jennifer Shipper, who's really been the backbone of this. And so really grateful to everybody for the leadership in this conversation. So today I have Lisa Levin from Advantage Ontario, Camille Kenville from the Canadian Mental Health Association, Ontario, Sue Vanderbent, Home Care Ontario, Amy Kopal, the Ontario Caregiver Organization, DP Sewer, the Ontario College of Family Physicians, Deborah Simon, Ontario Community Support Association, Melissa Prokopi, the Ontario Hospital Association, and Kelly Kay of the Provincial Geriatrics Leadership Ontario. So as I said, we came together to find a shared vision. So what we're going to talk to you about today is what anchored us. So we're going to go through some data points, and a lot of the work that we did was actually sharing information to get a level set, because we all like to talk about aging in place and aging at home. And then we realized that with more than 45,000 people on a wait list for long-term care in Ontario, and the population bump that's going to come, it's going to take all of us working together to really reset and reimagine how we deliver care. And we didn't feel that we needed to look to government for the answers. So what we're going to present today is actually a consensus plan. So if we didn't agree, it didn't get into the plan. So that was a real challenge. It wasn't an easy feat, but we're really proud of the work that we've really done. So, with that, we're going to drive the discussion with data. So, the nice thing is that 80% of us will be able to age in place when we're over the age of 80. 20% of us likely won't and will need more specialized care. So, we really need to make sure that we're building out a continuum of care supports so that we can help those to stay in home who are able to stay at home, but also really think about what the continuum of care and services and living is. And in our view, um, long-term care is aging in place. It's aging in community. It's aging in a home, and long-term care homes are the homes of our seniors. As we think about it, only 13% of older adults today, though, receive home care services, and thanks to PGLO for your data, 20% of adults 66 and over visit the ED at least once annually. 2.5 million Ontarians don't have a family doctor. And we're also seeing caregiver burnout. 48% of Ontarians, almost 6.8 million individuals of our population in Ontario of 16 million, are either a caregiver now or expect to be one in 5 years. 44% of those in the caregiving role say that they had no idea of the impact caregiving would have on their lives. 72% providing care said they felt burnt out and they really don't know how they're going to continue. Additionally, as I said, 20% of people over the age of 80 will have complex care needs. This is an Ontario data point. You'll often hear that there are far more people who are in long-term care who do not need to be there, especially with Bill 7. Increasingly, the entry point into long-term care is hospital. It's ALC for individuals who cannot go home because their care needs are far too great and cannot be met in a normal home environment. Advancing dementia, significant mobility, and care needs really have an impact on one's ability to stay at home. We know that 75% of our residents in long-term care homes have at least 3 or more different medical conditions. 76% have cognitive support needs. So this is our long-term care waitlist graph. Our waitlist in long-term care has more than doubled in 10 years. It is, the last data point was March of this year, 45,000 individuals waiting. In our estimation, that list is actually at 50,000 today. We are also seeing an increase of transfers to long-term care from hospital ALC, as I said, the impact of Bill 7. And our population over 80 in Ontario is projected to more than double by 2040, 4 times the rate of the rest of the population. And the largest increases haven't actually hit us today. They will start feeling it next year, and we'll start to see the trend escalating through 2027 and then actually stabilizing. So we're going to level out. We're not going to drop. So this is putting real pressure on our communities and all of our systems that we're trying to navigate. It's why we really need to work together to find out, how do we think differently about how we provide services? How do we make this about people, not about home care, long-term care, mental health care, primary care, acute care? We have super segmented our healthcare system to the point that we've lost sight of who the people are as individuals, and we've lost sight of the whole person. Our OHA colleagues have recently shared their data that chronic conditions are growing. And this is work that the OHA has commissioned through IHPME. And when we start looking at the fact that 3 million Ontarians are expected to be living with major illnesses by 2040, so when we think back to that aging demographic, morbidity is also rising, and it's a major driver of health services utilization and costs. We know that an aging population will contribute significantly to the estimated increases, but also structural and social determinants of health and an increase in chronic disease risk factors are having already beginning to have an impact. And finally, research conducted by our association, the Ontario Long-Term Care Association, shows that older boomers, those 68 to 76, have thought little about their future living and care needs. They've not discussed it with their family members. They do not think they'll need specialized care. They have not planned. They simply have faith that the system and services will be there for them. So, as we were looking at this landscape, we really wanted to step back and think about how do we think forward. So we really appreciate the government's investments, certainly in long-term care. The investments by the government of Ontario are historic. They also are far more significant than investments made in long-term care, especially following the pandemic, than any other jurisdiction in Canada, any jurisdiction in the United States, and any of our partners globally. And we're just catching up to do a correction. We actually need to step back and think about the flow of our residents, our patients, about the people who live in our communities, and how they move through and flow through primary care, home and community care, hospital care, mental health and addictions care, and long-term care. And we have to step back and look at local partnerships. So, not just looking at provincial cookie cutters, but really start to think differently about what are the needs in rural Ontario? What are the needs in Northern Ontario? What are the needs in Toronto? What are the needs in the GTA more broadly? And start to think about individuals within the context of their communities and how partnerships across the continuum of care can actually better support them in their communities. So, we're a group that is actually talking about whole system thinking, whole system planning, and really thinking about multi sector planning. At one of our sessions more recently, we had a representative from the SCAN Foundation, who is a philanthropic organization that is leading work out of New York and California around multi sector planning for aging or master planning for aging, where the health system isn't in isolation. It's about transportation. It's about housing. It's about employment. It's about family supports. It really is a different framework and a different paradigm that crosses multiple departments and ministries and just isn't the silo of the Ministry of Long-Term Care or the silo of mental health or the silo of the Ministry of Health or the silo of rural affairs. It really is a much more integrated, cross-functional and matrixed discussion that we've been having. So we are really inspired by our discussions. And so today we really did want to take this opportunity, as Matt said, to really share this work. So in a minute, I'm going to turn to our panel members to talk about their experience in this and what they're doing and their thinking. But I just wanted to touch on our action plan. And we tried to keep it as simple as possible. You will see it is cross-functional, and we tried to really make sure that it is about practical solutions that can be expanded to reduce the long-term care waitlist or avoid admissions into long-term care, help more people with complex care needs age at home and age in their communities, and fast track access to long-term care for those who will need it. I won't go into all the details. You can actually see it. So it's expanding services to enable people to live and age at home, bridge services to get people out of hospitals and back to home, expand supportive and affordable housing, and prioritize those with the highest need to actually access long-term care. So with that, I'm going to turn to our panel, and this is going to be interesting. That's why I'm standing, so I can see everybody here. So I'm going to actually start with each one of our panelists individually to really speak to what can we do differently And what do our sectors need from one another? So this is about codependency.
Thanks so much, Donna, and good morning, everyone. So I'm with the Hospital Association. So I think coalescing around the why has been easy, to Donna's earlier point, and coalescing around the what to our action plan has been straightforward. I think the how is what we're all grappling with on a regular basis. And I think the good news for us in Ontario is we actually have the talent and the credibility and the innovation in our own backyard. So from a hospital perspective, half of the country's research hospitals live in Ontario. We have amazing technology and innovation emerging every day across the entire healthcare system. And there's opportunities for us to do a better job spreading and scaling those technologies. It's not about working harder, it's about working smarter, because we have limited HHR, and Donna talked about the impact on caregivers. So we need to find new ways across the continuum to avoid hospital admissions, to keep people at home, whether that's long-term care or a home in the community, and give them access to the services that they need to keep them healthy. We know AI right now is a huge opportunity, but there are so many other technological advancements, and this is something that the Ontario Hospital Association is really excited about. There's things like precision medicine. There's things like wearables and virtual reality. There's things like regenerative therapy and gene therapy. There are ways for us to understand how to more purposely and intentionally treat people's conditions, illnesses, and challenges to allow for them to recover faster and in the community. Then the other thing I'll say is I think, thinking upstream to how we prevent some of these things that Donna alluded to. The work that we've done says we are going to have an onslaught of chronic illness in the next 15 years in the aging population. Much of that is both preventable and or there's an opportunity to delay the onset of that. And so we have a collective responsibility to work with our upstream partners as well to figure out how to create a healthier population that ultimately doesn't need the same access to services that they need now. I'll just give one example and then I'll pass it along to Sue. And there are tons of examples within healthcare, not just in hospitals, of how technology is being used. And we see it every day in the media and the success stories across our sectors. But, Bright Shore is using an AI wound tool to be able to diagnose and treat and provide insights to its patients within its four walls. That's something that we could be expanding to be used in the community to help aging populations in long-term care or at home. Hamilton Health Sciences is using a virtual rehabilitation model to provide more rehab to people in the community as compared to the existing model of one-to-one therapy. So there are lots of examples. I think our job is to find ways to spread and scale those at a fast enough pace to keep up with the population as it ages dramatically.
Well, hard act to follow. So thanks very much for the invitation today. So we just had our symposium yesterday for our members. And I was just to riff a little bit on what you were saying about predictive analytics. And one of our presenters was talking about how we can prevent UTI infections and hospital admissions by actually kind of monitoring in the home how many times an elderly lady goes to the bathroom. Because the less she goes to the bathroom, the more likely it is she's going to end up in the ER tomorrow in a serious state, and then she'll go up to one of the medical floors, and then we will have difficulty placing her or getting her back home. And that's the story of hundreds, literally hundreds of thousands of people, and that's why they pool in ALC beds. and the discharge is very, very difficult. And I say this with a fair degree of experience because I worked for many, many years at St. Joseph's Hospital in Hamilton, which is a big teaching center and also a very, very busy hospital. So some of these wearables where we can start predicting that this lady, we need to get some help in there to deal with her because she is representative of many, many others who are following in the same path. Also, the frail and elderly, and I'm reminded of a patient that I had, and I'm just going to call him Mr. Smith. And Mr. Smith was coming to the Firestone Regional Allergy Clinic because he actually, and also the lung clinic, because he was dying of emphysema. Actually, he was in his late 80s, and he met me as the social worker, and he used to come to see his respirologist. And when he used to come and see his respirologist, he always used to come over to our department for a cookie, a cup of tea, and $5. And that's what he would come for. And that's why he lasted. He actually lived for a couple of years longer than he probably should have. But it is this personal issue because C. Wright Mills said private troubles are public issues. We all know that, and there are hundreds of Mr. Smiths, and there are thousands and thousands of people who are now creating a UTI. By not looking after themselves, not drinking enough. Like it's these little things that we're talking about that need to be addressed as a community. So two areas that I think we could talk about, and maybe that's for later in our conversation, that I think are very important are the hospital care at home programs. And this is something that is new and is very helpful. And then the high intensity supports at home. So this is like an extension of the care that people would receive in the hospital. Because as Melissa says, we cannot have people pooling in our medical and particularly our surgical. I really shouldn't say particularly so, our surgical beds, but the reality is that's when you back up surgeries, that's when you back up your ER. And one of the biggest problems that we have right now is the home care system and the community care system is built to try to keep people at home, but the funding doesn't help us do that, and therefore our hospital ERs cannot move and they're in stasis. And having worked in ER, I will tell you, and I know people here do work and have worked in ER, but it's a crazy place, a difficult place to work. And we just cannot leave the ERs unprotected in this way. And we have to think about this systemically, and all of us take responsibility for this. And I think that's what Donna's initial message was. And that's why this group got together to say we all play an important role. And we have to start thinking as a true system. What happens when we leave one part of the system undeveloped and unresourced? It will impact the whole system.
Of whom are aging. What does that look like in terms of how we're caring for them? Are we ensuring that they're not lonely? Loneliness is a huge issue as it relates to mental health, certainly in senior citizens. How are we ensuring they're getting the care that they need in a timely way? And by that, I mean, are they seeing their primary care provider? Is that primary care provider connected to community-based care? Because quite honestly, those connections don't always exist. And if they did exist, that transition would be much easier. It would mean that there's less emergency department visits from people who are finding themselves mentally unwell. And quite truthfully, if we did nothing else, I would suggest as a group, and I think we will do many great things, but if we did nothing else other than to make that connection much clearer and much easier, then that would be time very well spent. It would do great things for the healthcare system. So a big plug to connect primary care and community-based mental health care. The use of technology is huge, particularly as it relates to telepsychiatry, serving other parts of the province, connecting them to caregivers who frankly are mostly in central Ontario, where there's a propensity for those kinds of professionals. And finally, I would say, and Amy, I hear you, caregivers of people certainly who help family members with dementia and other related illnesses, that is a huge issue. And there is much work to be done there. So also.
Great. Thanks, Camille. Such an important topic. Deb Simon.
Thank you so much. And I think the great thing about being on a panel like this is that if you wait to the very end, you let your colleagues actually say everything, but Lisa gets to say the last word. So I don't want to be a Debbie Downer, no pun intended here, in terms of, but I'm sitting in front of an audience that has probably heard a lot of the very interesting statistics that we've heard when Donna presented at the beginning. And I can recall a good probably 10 years ago, sitting and hearing a presenter talk about the tsunami that was coming. And at that point, the wait list was around 35,000 people waiting for long-term care. And now we're 50,000 and we're past being in it. So I'm really, I think I'm the one next generation that's going to be going into that so-called tsunami, and I'm going in screaming and kicking about it. So I'm ready to take action. The beauty of what happened with this group in terms of the planning is that we did it across sectors. And I'm still 10 years later not seeing that happen. I'll go back to my respective tables in home and community care. We're trying to plan out a system all by ourselves, and we have not changed that paradigm in over a decade. So I think the solutions and recommendations that you've seen in the report are just the beginning of what could possibly happen if we actually could start to work together. I think the secret sauce to this, for sure, is access and flow. And certainly people are going into long-term care not because they need 24-hour care, but because of a failure on the home and community care and community side in particular. We have not got the resources to be able to support people to age in place, and that has been going on for way too long. I'm really excited about the idea of a home-first approach, but I'm not sure that has penetrated across the board. I think it's still pretty much restricted, and acknowledging that home is an appropriate place for people to receive their care. We have to be careful about that. And Amy did talk about caregivers. We were talking about medical homes. I hate that term. All of us retreat to our home. We need to be able to deliver care in the community, but we've got to be careful to make sure that people who are receiving care in the community are supported in the right way, and that their home still remains a home, despite the fact that they might have 24-hour care coming in to support them. On the solution front, our organization has been looking into what is working right now. And there has been the emergence of some great models on community wellness hubs. And now I'm talking to the 80% of the people who don't need specialized care, who are seniors, but they want to be able to continue to stay in their communities. And there are a number of really great emerging models that have been in place. We ourselves had looked at PACE-like models of care, and there are a number of them that are similar to that, modified with a focus and hub on how to integrate primary care in some of those communities, how to use housing as a solution, how to reduce social isolation that Camille was talking about, all of these things that will keep people from actually progressing and needing to have the more acute care in their communities. So I think there's great themes on what can be done going forward. We certainly are really looking at a need for addressing navigation and coordination, but not the way we've been doing it to date. And looking at redefining roles. We've got, again, 10 years later, the ability to go across teams and work in a more integrated manner. And I think we need to take advantage of this. I don't want to see folks sitting in a room 10 years from now talking about the same thing.
Thanks, Deb.
I have
And
to
Lisa
say-
Levin.
So I get to go last. And what I would say to you is we know how to fix the problem. We know how to deal with the fact that, well, and it shouldn't be a problem that people are aging, but the solutions are limited, it seems, to ALC, long-term care, retirement housing for those who can afford it, and home care for those with the highest needs who have caregivers. And I'm sitting here on this stage, and I feel like if I go a little too far back, I'm going to fall over the edge. And if I go a little bit too forward, I'm going to fall over the other side. And that's kind of like what our healthcare is like. But really, we should have a large stage because we have so many options and we know about them. We know that we need to have community care that doesn't have copay, that is broad and well-funded, and that people can access. We know that we need to have supportive housing. And so that's for people who can't afford retirement housing. Why don't we take all of the seniors housing buildings across Ontario that are not for profit or co-op and put supports in them? That is supportive housing. We don't even have to build anything to do that. So, and oh, it's cheaper. It's $62 on average per person per day versus long-term care, which is $200. And if you put people in environments like that, a lot of times they don't need to go into long-term care, or it certainly prevents them from being there. And oh, they're happier. They're in their own home that is a self-contained unit. Their independence is at the best level. When I decided to go into this business, it was a long time ago, and we knew this tsunami was coming, which is why I decided to go into seniors care. And guess what my thesis was on? Supportive independent living for seniors. So here we are, it's 2024. Why has nothing changed? We know what to do. So how can we each make it happen?
Thanks, Lisa. Thanks, everybody. So some interesting themes here. And each one of you has touched on some really concrete solutions. So, Melissa, you introduced AI and digital opportunities. Sue, you're talking about some of the flow issues and really anchored it in the human experience around just how some of the little pieces of things can actually sustain a life and support somebody living well and living longer. I have to say that I was really inspired as well with respect to the team-based care and primary care, and how do we think differently about what a team actually is, and starting to rethink around connectivity and flow, as well as thinking about our family caregivers at the core of this, and whether that's in a hospital, whether that's at home, what is the role of a caregiver, a more informal family, friend, neighbor, colleague, as well as looking at the role of respite that it plays in the system. And I know Camille knows I'm really passionate about mental health and some of the models that we can actually learn from in other parts of the system. Mental health sector has been doing virtual mental health, telemental health for the last, at least the 30 years that I've been involved in the mental health system. How we reach the north and more remote communities, I think lots of lessons to be learned there. Deb, love your passion as well as you think about doing things differently around those home and community supports. And Lisa is one of our biggest advocates on supportive housing and really brings a really strong vision to it. Recently, I had the benefit of being a guest of the government of the Netherlands, and I'm looking over at Zaina here because she's done a lot of work there. And one of the themes that really came out when we were meeting with government officials was the trend. So 15 years ago, they were talking about affordability. 8 years ago, they were talking about quality. And today, they're talking about accessibility too. And so really seeing accessibility come to the fore. But when we're looking at the complexity and the multimorbidities, it's not just accessibility to one service. It's how do we treat people as whole humans, which is really resonating here. We have a lot of pilots, and really appreciate Kelly commenting on long-term care without walls. Maybe that's going to be another pilot. It's emerged out of New Brunswick, really innovative. Given what each one of you has spoken about, and I'm going off script here, everybody, I'm wondering if we can get your comments around how do we think about sustainability? We have lots of pockets. I know thinking about a UHN Victor Institute pilot around cardiac monitoring and remote monitoring with wearables. That's a pilot. We're doing a pilot on cultural homes in Ontario for long-term care homes and admissions into long-term care. But how do we think about scaling things that actually work, that are anchored in the experience of the people we're here to serve? And I guess the subtext of this as well, as we think about the work that IHPME has done around what we need to be preparing for around chronic illness going forward. What we don't have, and I would say the other shoe to drop on that is, what's the census of professionals who are going to be around to serve those needs? Haven't seen any data on that. So I don't know how many cardiologists or respirologists or geriatricians or oncologists that we're actually going to have, because we don't have a track or line of sight as to who's retiring and who's actually coming in. And I think that's going to force us to work differently as well. So Melissa, I'm going to start with you around where do we start and how do we sustain it?
I love going first. I'll just say on that last point, Donna, just one data point coming out of our study is 1 in 10 people who are eligible to work right now in Ontario work in healthcare already, 1 in 10. And the growth of the working population is at a much slower rate than the growth of the population over age 65. So that gap is narrowing significantly. So what do we have to do? I think we need to stop creating capacity in the system that we have and start thinking about the system that we need. And that means leading by example. You're right. We love our pilots in Ontario. We are a land of pilots, and we haven't collectively figured out the best way to spread and scale and show the return on investment for the patient, for the community. Hospitals are the most expensive type of care. So we need to show collectively how these opportunities present better access, better care in the community, whether it's primary care, mental health and addictions, home care, long-term care, whatever the services are. We have an opportunity to be a bit bold. And I think that also means taking some calculated risks. It's something that we're collectively not good at. But I also think that no one's going to be giving us the answers and giving us the roadmap for where we need to go. So I don't think it's a should we? I think it's we have no choice, because if we don't do it now, and I'll just, Lisa, kind of building on your point, like we've been talking about this for 25 years, the silver tsunami, and Deb, you mentioned it as well, like we are here. And so we now have no option but to do something different. And if COVID taught us nothing else, it gave us the ability to be resilient and adaptable to kind of serve a common purpose. We all were focused on the same objective, and we did it. And so I think we need to take from that this idea of rolling up our sleeves, taking off our kind of sector-specific hats, and kind of parking our own individualized mandates to the point that, Donna, you made in the beginning, which is how do we think about this from a patient or a client or an Ontarian's perspective? And that means we might be thinking about things a bit differently from the hospital perspective or from the long-term care perspective or from the community perspective, but it's what's necessary for the community for us. So I'd say, in summary, be bold, lead by example, and be prepared to take some calculated risks to move things forward.
Thanks. So on my theme about protecting the ER, I think that portal is got to be protected. We are looking at some really interesting programs like hospital care at home. And this is really an interesting program. I think it has a lot of merit and it's practical. So often the portal is the ER. That's where it all happens in terms of decision making. The hospital will case find, an ER will case find patients who could benefit from really super, I would say, rehab. So not just a physio or an OT who sort of comes in and looks at us and says, "Oh, we could order a couple of exercises for you to do." What we do is we look at actually. Using scales like the RI, the Resident Assessment Interview tool, where we assess what are the actual rehab needs that the person has. And from that, we admit them to the hospital at home program. And it is 16 weeks of intensive OT, PT, social work, PSW, nursing, speech language pathology, dietitians, RT, rehab therapy care. It allows the team that would have been years ago in the hospital, who are now outside of the hospital, and to have that time to do the rehabilitative work that is critical, to actually try to get somebody to a better spot, to engage with the family caregivers, to engage with the family doctor and let them know that this team is in there, and to really look at what gains can the senior who has been failing, and we see that they are neglected, they are failing, the caregivers burning out or not showing up because they don't know what to do. Um, and this program does help in terms of rehabilitation, which is where we can arrest the first sign that the family and the family member and the patient is starting the sort of the cookie starting to crumble there. So um, admitting a patient to this hospital care at home program with all these types of excellent resources related to the disciplines, we are seeing scalable results. So the RISE scales, which most of you know as the Resident Assessment Interview scales, clearly are showing an improvement in patient function. They are showing reduction of frailty. They are showing reductions in risk for hospitalization. And they are showing that people can improve their activities of daily living, which ADLs, these are a lot of terms that we use in rehab, but like to get that rehab team in there quickly and really try to pull that family and that patient back from the jaws of, of the acute care sector, because it becomes almost a period of time where people get pulled up into the medical beds. And so there's another one as well called high intensity supports at home that is a similar type of program. And we certainly will connect with the family doctor. For many, many years, primary care and home care has said we should be more connected. Why are we separated from our family doctors? We need to be more connected in terms of what the family doctor is seeing, what the family doctor is trying to address, and how can home care work more with primary care. So these are two, I think, programs which have a rehabilitative sort of wall to them, but they also can serve to strengthen the family, strengthen the patient, and strengthen relationships between us as caregivers. And the place where it often happens is in the ER, because that's where you can do a lot of case finding. But the other very clear case would be with the family doctor. If the family doctor is the one who could say, I'm seeing this patient, lowered sort of scores in terms of they're frail, they're feeling neglected. The family has sort of not abandoned. Abandon is a hard word. Just burned out. The daughter didn't come for a couple of weeks. We didn't see, and now I see my patient in the hospital with something that we could have avoided. So I think we are seeing glimmers of some things that could really be expanded and refined, and working together and collaboratively is how we work with hospitals, we work with family doctors, and we work obviously with our community supports and with home care to pay attention. And a lot of it is paying attention to this one person who could end up for the next year sitting in a medical bed.
Thank you, DP. So it's over to you to talk about you talked about team-based care models. How do we scale that? Like, how do we make that become a reality, and how do we scale it and sustain it?
Yeah, I'm listening to the stories that are being told, the stats we're sharing, and I'm kind of thinking about the room and my own experiences as a clinician and having worked in the system, and I've been a consumer of the system. And everyone knows someone who's lost their family doctor, who's moved and traveled 100 kilometers to see their family physician or another provider, who's hanging on for dear life because they don't know where else to get support, and that's the front door to access. Who's worried about a mom with mental health or diabetes or both or some complexity. And we can all tell that story or have had that experience. And I think about sustainability, and what sustained us is two things. One is equitable access, and we see what it looks like for us here in the downtown core, in the GTA, and what it looks like in the northern communities. I'm from Brampton, and I know it looks completely different than when I travel just 10 kilometers north or south of where I am. And that shouldn't be the case. I know a sister who's got a great team, and I know a brother who has no access to team. And that's not what we want our system to look like. We want people to have front door access, right time, right care, right moment, and we want them to be able to see themselves in the future with good, surrounded, team-based care and health. And we also know we want our teams to be working well together. So it's not co-location and just collaboration, but working well together and working with our family physicians and working with other healthcare providers in the system so that we see some moves and changes. And the second thing I'll say, because I know so many of my colleagues are going to capture other great things to build on what we've been talking about, is the infrastructure support. We need to see investments, and we know we all need to see investments and long-term investments, not just piloted, but we also need to equip people to be able to do what they need with good technology. Healthcare is one of the most behind technological industries in the world. And so we need to change that, and we need to leverage the data to give people what they need to have the supports each day to be able to see the patients, communities, and families they serve. So that'll help sustain us.
Great, thanks, DP. And I love your introduction of data sharing, connectivity, really supports those transitions and those shared team-based approaches. Amy, caregivers.
Well, I'll pick up on the idea of sharing in terms of looking for creative ways that we can build on the funding and programming that we already have in place. And I'm going to give an example of something that Camille and I just kind of cooked up, and it worked. So she has a program that's for healthcare providers to support their mental health, and we have programs for caregivers. And so we talked about, well, there are healthcare providers who then go home and serve as family caregivers. So we call them double duty caregivers. It's 24/7 in many cases. And so we pooled our resources and developed an initiative that supports these double duty caregivers, gives them information, resources, and some tools that they can use on their own journey. And nobody told us to do it. Nobody gave us extra money to do it, though we wouldn't turn that down, might I add. But we can come up with these creative ways of saying, well, what do you have and what do I have, and how are we serving these common populations? So that would be one thing that I would recommend. As far as caregivers go, when we are making these changes, it's really vital that caregivers are included throughout all that planning and ideation process, and not as a consultation at the end, but really making sure that the consideration for the caregiver experience and need is factored in. And then lastly, I would really double down on the essential care partner piece, because this is incredibly low-hanging fruit that anybody in any healthcare setting can use today. And it really is so simple in terms of, do we have our caregivers identified? Do they know their caregivers? Do we have them really included as a part of the care team, recognizing the knowledge and the history they bring, but also factoring it into transitions? And then are they connected with support? Whether it's a home care provider going in the home, whether it's an ER visit, whatever it is, are we making sure that those caregivers are being caught earlier? Because the amount of times that I hear from people, oh, I wish I'd heard from you sooner. I wish I knew you existed sooner. You know, if we can look at what are those pathways to recommend and refer caregivers to organizations like ours, or an organization that may be supportive of the condition of the person they care for, those things can really make a difference in helping prevent some of the breakdowns of some of those systems and structures for people over time.
Great, thanks, Amy. Love the concrete examples of things that already exist and that can be scaled. Kelly.
And just to add to some of what my colleagues have already said, I really have two ways that I can see sustainability unfolding. And first, I just want to frame my remarks by reminding us that it's a really positive thing that we're living to 100. and I hope to see you there as well. So I want to start off with the practical that comes to my mind when I think about sustainability. I think about educating the health and social care workforce for the population of today and in the future. Some of the ways that we're starting to do that, we know that a lot of basic programming for health and social care workers doesn't really include a major focus on this population, the population living with frailty. The concepts related to multi-morbidity are complex, and it's more than just the washing, feeding, and dressing of older adults that we're talking about. It's understanding what matters most to them, helping them to actualize that. And one of the ways that we're helping to support that is we deliver a provincial common orientation to the care of older adults. We've already been able to train 800 health professionals in an unfunded program. Watch for your sponsorship packages. and we have had 130 organizations send staff, more than 30 different kinds of health professionals participating, from chaplains to social workers to all manner of nurses to community paramedics, and as well we include content from my colleagues. When we're teaching our health and social care health professionals, we're including and connecting them to content. We also provide education for care partners so that they know how to respond to some of the things that they see related to frailty. So what happens when you're having trouble giving somebody their medications? How do you help them eat when they don't want to? And we invite the caregiver organization into the last session of every facilitated session so that we make the links, and caregivers are not left wondering, is it your organization? Is it your organization? Who do I go to? So we help to forge those linkages. I'd also like to say sustainability includes the kind of models that DP was suggesting. You know, in a past role, I worked in a family health team, and when we implemented team-based care for diabetes, we saw an impact on hemoglobin A1C control. So we know that it's possible, and it's important to have those teams embedded in primary care and under the leadership of primary care. So I'd like to see primary care integrated geriatrics or frailty-focused teams that can work directly with primary care physicians. We've really got to get away from referral-based models. That just creates wait times. And if you think about, I'd mentioned earlier, we're referring people on to 11 different services and programs for support. every single one of those has a wait time. So we need different ways of integrating so we don't just pass along the wait time. We've talked earlier about other important innovative models that are emerging on the landscape, like long-term care without walls, like naturally occurring retirement communities, like community wellness hubs. I also want to shift to the second major point I'd like to make is we do need a policy infrastructure that supports this work. As much as we can do together, we also need policy leadership in this area. We have the issues that face people living with complexity cross ministries. So we really need a whole of government approach. And we also need some defined leadership that's assigned the responsibility of implementation. It's kind of my hope I'm sitting with a future board of directors for some sort of agency responsible for helping with implementing the work that's to come to support the aging population.
Great, thank you. Much food for thought, Camille.
Thank you. Donna kind of referenced this, so I'm going to pick it up and run with it and tell you about a program that the Canadian Mental Health Association runs in Fort Frances, Ontario, which of course in northwestern Ontario, very remote and rural community. And it was once upon a time had a very robust economy as pulp and paper mills were active. Everyone's nodding. We've all seen this movie, and sadly those mills close and a generation moves out, and you have an aging population in place in a community where there are not a lot of resources. So our branch proactively goes out to individuals who are seniors to ensure that they have what they need to be healthy and to stay in place. And I was actually there not too long ago and saw the efforts they make to keep the community healthy. And by that, I mean they provide everything from having a dental hygienist come into our branch. It's a place where people could come and have just day programs to keep them connected. There are long winters there, and people can get very lonely if they are shut out in their own home. So what they do for a population 60 years plus that have serious mental illness or dementia is they use telepsychiatry through Baycrest here in Toronto. And this obviously prevents them from having to travel for that kind of service. It is an excellent service that works well for every part of the system, most particularly that individual who typically does not have to wait for the kind of care that they need, that specialty care that they need. They also have programs that they use through Mount Sinai Hospital in Toronto that supports caregivers and those working to help those individuals who are living on their own. And they also access workshops that are Toronto based as well. So those connections help keep those individuals from seeing the doors of a hospital, from ever walking into an emergency department to get to the kind of specialized care that they might need. And it works. And it really just flies under the radar. It's something that we really need to be scaling. To Donna's point earlier, there's no reason we couldn't do this in Southern Ontario, and it does exist to a lesser extent in Southern Ontario, where we have remote communities or rural communities where individuals aren't able to access the kind of specialized care, and particularly that they need for their mental health. So I will share that, and hopefully we can focus on these areas where we know there is some progress that we've already made.
Great, thanks, Camille. And it really is having these discussions to talk about, like we're learning from each other. So, when Kelly has Amy come in and talking to DP, and we're talking to Sue and Deb and Melissa and their teams, we're all trying to figure out who's doing what and what's transferable. Like we don't need to create this on our own. There are programs and models that actually work that can be replicated and scaled. Deb, you're the big champion of the wellness hubs.
I actually think we're missing the point in all this big discussion here, and I appreciate the room and the audience and what we're trying to do, but I think we're so deep into this crisis that we don't really realize that we've got a huge issue on our hands in terms of how we're going to handle the next 10, 15 years. And so I think there's some agreement to that. If we continue to plan like we are right now, we are going to see a crisis in healthcare like we've never seen before. I think what was really unique about the planning that we did as a group here is that we kind of cut across all kinds of sectors when we talked about how could we work together and turn the healthcare system on its head. And I think that is the problem that we're trying to work our way through right now. I can't do it in my silo of home and community care. It just will not happen that way. And I'm not sure. I think I really can't wait till we get to the Q&As because I'm really interested in what people think we can do from a political a system perspective to really push things forward here. We're all doing great work in our respective areas, but it's not enough, and it's not going to be enough to be able to continue to handle the large component of seniors moving in who are going to need literally crisis care as we're going forward. So I'm not going to waste the mic and talk about all the good things because I know there are excellent programs, but I would really like to get to the meat of the discussion around how things can be really different.
Great point. Thanks, Deb and Lisa, and then we'll move to Q&A.
So I would say the way to have sustainability is to stop doing pilot programs for things we know work. Right? How about that? So certainly they have a benefit when it's something new and innovative that hasn't been done, but like things that work, what are we evaluating exactly? So supportive housing hasn't had an increase until last year for so many years in their funding. And that meant services eroded, less and less people were being cared for, and some providers closed their supportive housing. We don't even know where it is or how much there is. We know we have 82 members in our membership, but during COVID, I couldn't even get vaccines into those homes because government didn't know where they were. So why don't we look at what we have? Why don't we look in our own backyard, see what's good and invest in it and help it grow? Now, if you want to create more supportive housing, good luck to you. It's a haphazard luck. You have to have a lot of luck and you have to have the right person to talk to at Ontario Health because that's the only way you're going to be able to do it. Now, why is that? Is this like this strange, innovative, bizarre program? No. So we need to have a pathway, a way that you can go and get supportive housing for seniors who are frail in your community so that you can get capital funding if necessary and operating funding. We have so many buildings, Donna, that need to be redeveloped between our membership. There are buildings that are sitting there that are going to be turned to something else. Why don't we turn some of them into supportive housing? We have members that want to do that, but there's no way to get the funding to do that. So we are really losing an opportunity. So I would just say, let's just normalize things that maybe aren't super exciting. Getting rid of loneliness, is that boring? No, it's essential. Let's take the essentials, let's take the basics and make them normalize and fund them.
Great point to end on. I think Dr. Philpott's going to be very busy in terms of everyone looking to her to solve the problems. To Deb's point, we need some real leadership. And I feel confident we've got leadership at this table, but we do need our political leaders to actually help us get the pieces in place. Legislation can be changed. Regs can be changed, laws can be changed, and we need to break down the silos. So I'm going to hand it over to Matt now for Q&A.
So we have a couple minutes for questions. Now is not the time to be shy. Now, before I do that, for those of you who are online, the questions are going to get asked here, and we're not going to get to all the questions that everybody has, but because we have a number of people here, they get to network after the fact. All right, so it's just a little encouragement. Don't be afraid to come on out, except for those of you who are in Thunder Bay. It's a bit of a trek, but if you're local, you need to come out to these events. You need to come out and network. Those are where a lot of things happen. So I'm going to start. I saw a hand down here, and we'll start down here.
Thank you very much to everybody. My name is Tracy, and I'm going to give you just a little bit. I'm an innovator, and I have a company that deals with scent and cognition, and we work with about 500 long-term care beds in Ontario, and we're moving to Alberta. And I'm listening to you all, and I respect all of you, but I'm going to ask a question. Do you have an innovator on your team that can help you scale? This is a question I ask because I deal with government, I deal with medical institutions, and it's very slow. And I move very fast, and people like me, and I reference big creative thinkers who have no money, who come to the table, who disrupt and change, have a different lens than you all. And so if you want a problem solver, you may have to incorporate someone from the private sector, someone who is an AI developer, an engineer or a coder, I'm a perfumer. So I come from it from a completely different perspective. But scalability is part of business development, which is moving fast. And I hear the medical industry consistently all the time. And Heather and I were speaking about government needs to have less politicians and more innovators coming to the table so they work collectively together to develop better policy. So that's my question to you all.
Anybody want to start?
I'd say thank you. That's a really interesting perspective. Don't write us off just yet.
No.
I think there's a lot of innovation happening. And I think, but you're really pointing out something that's really unique. We talk a lot about interprofessional practice within the health sphere. I had the good fortune to be part of the training program at the Canadian Frailty Network, and they talked about interdisciplinary fellowships. And that was the first time. I thought they just made a typo. And that's me with my health bias. You're absolutely right. We have to look outside of the traditional ways of doing things and partner with people we haven't partnered before. And I think it takes some courage from the health sector. I know my colleagues are already heading down that road. So thank you for raising the question. It's a good reminder to all of us that the solutions are not necessarily going to be found within health alone. So thank you for that, but I'll turn it to others.
So I think there's a unique opportunity for private industry to contribute to our healthcare system in a way that we haven't seen. I'll ask us to reflect on how we think we're doing right now. And I would say, I think collectively, we all feel like we need to do something different. I think government agrees with that. I don't think that there's any sense or posturing that this healthcare system, the way it is now, is working well across any of the sectors that we represent. So I think we have a unique opportunity out of necessity to say, as a collective group of associations and organizations, how can we work with private industry, with our members in a way that's evidence-based and data-driven to bring things to the table that we know will be successful, that are not just better for the patient and for the provider, but are actually better for government in the long run. So I think it is an opportunity, and if we don't collectively take advantage of it now, I'm not sure we're going to have another chance or another opportunity. And we're 15 years out, and frankly, I think we're already too late. So now is the optimal time for us to try to accelerate all of the things that you were talking about.
Just very briefly, thank you so much for sharing that. It's really helpful, and I don't think anyone, as you pointed out on this stage, is wedded to the way we're doing business now. In fact, that's actually why we're here. I'm going to point out Zaina, because we actually brought Zaina in to speak at one of our meetings not long ago, and she turned the entire conversation on its head. And to have somebody who's talking about future thinking as it relates to healthcare, and the story she told brought everyone's imagination to a different place around what we were actually doing. So do I have somebody on my staff whose title is innovator? No. Do I have a lot of innovative people? the program that Amy referenced that we worked together on, we just built and designed that in-house. We went to government and said, we're doing this, whether you're with us or not. And they said, we're with you. They cut us a check, which is a good thing because it's supporting frontline healthcare and their mental health. So we have a very long way to go, but thank you so much for raising that.
Just in the back corner here.
Thank you so much. Robert Stanley, stay-at-home nursing in Cha, and just thanks to Sue for a shout out about our new AI technology that does detection of things and dispatching like falls, but also prediction and prevention of UTIs, of pressure sores, of preventing falls or exit seeking. So I'm glad to hear that there's a lot of talk about innovation being a big part of the solution. My question for the panel is this. Yesterday I saw Matt Anderson speak from Ontario Health, and he was talking about the fact that Ontario Health recognizes that home care and coming back with more preventative stuff is good, and intuitively they understand it, but he struggles because he doesn't have data or information that actually proves it. And when I was hearing that, I was thinking to myself, I've seen an argument, and I'm just wondering if the panel has seen this or if it's common, where when we project out the needs for long-term care beds and hospital beds in Canada by 2031, a conservative estimate we've seen is $250 billion to build them for capital expense. Operating expense is about $120 billion. And when you look at home care and putting that same level of care into the home, it's about 10% of the CapEx because we're using a capital asset, our homes, where we all want to be, that's already there. We don't have to build it. And the operating expense, to Lisa's point, our white paper talks about 30% operating expense. So 120 billion, 30% of that, which is 62 out of 200. So is this argument being made? Are people talking about this? And if not, why not?
Right down at the end.
I have made this argument so many times, and I thought for sure with a Conservative government, they would listen to our business case. So I honestly don't know what's stopping us, and I could use some help. So if everybody could give us some suggestions, because there's a lot of smart people in this room, on the stage, but in the room as well. What does it take? What is it going to take? Because it is cheaper, we know it, and it's what people want. Oh, we have an answer over there.
I don't know that I have an answer, but I just wonder if our panel needs to be the baby boomers of the future. The boomers who are coming in. Deb, when it's you and me on that panel, speaking for what we are screaming about, it'll happen. So I just I don't know, folks, we all talk a lot about the collaborative and all we can do, and we've got it figured out. But the voice is the patient, is the individual who needs us, who needs this care, who needs to live at home. We need them to shout it from the rooftops.
I was going to say, it's a shame we wasted a great crisis not really taking advantage of coming out of the pandemic with a different view of how we could actually address this. But I agree.
So we have time for one last. I want to move on to as many questions because I know that one question we can spend probably an hour answering. So this will be our last question.
Thank you, everyone. Really appreciate the panel today. My name is Jack from Obio. I do have a positive note for everyone. So during COVID, we've been doing a lot of private public sector work on technology adoption, not pilots, adoption. So we started off with 8 hospitals. Now we've gone up to 150 hospitals across the country. Yes, it's hospital focused, but long-term care, we see a lot of Canadian technologies out of Quebec, Alberta, Ontario, BC that are working with us, that are being adopted in long-term care facilities across the country. It is coming. Just give us more time because it does require the public and private sectors to generate the evidence. Once the evidence is generated, then we go straight into our adoption and procurement programs. So that is happening. It's not something that's in the future. It's happening today. Just give us a little bit more time because we will be building out a lot of those capabilities in your sector.
Just to respond to that, I think on 2 points. First of all, I really appreciate the efforts of the innovators and all the work that's happening to introduce technology and artificial intelligence into this space. I'd also like us to think about the acceptable use of artificial intelligence and technology in the care of older adults. It is a high touch environment, and there's some work that certainly we've heard the examples of the digital and the virtual services in the north. And lots of really great examples that combine both. So thank you for the work that you're continuing to do. And I think we just need to be mindful about how that happens. The other thing I would say is I just would challenge the search for evidence. I would say we privilege quantitative evidence. We have a lot of quantitative and qualitative evidence, and we ignore the qualitative evidence that is actually reflecting the true experiences of older adults. It's not nonsense. It's not just storytelling. It is evidence, and it can point us in the direction of the actual policies that need to be changed. So I would just sort of caution us to think we don't have enough information to move ahead. I think we actually do.
Quickly, Longwoods is very well known for stopping dead on time. Okay, so Amy, you have about 1 minute.
I'd like to propose a model for thinking. Stay on a Venn diagram with me. We need innovation. We also need simplicity, because a lot of these things are simple, but let us not forget about humanity. Loneliness has been talked about a lot today, but not enough. And we need to look at what's in the sweet spot across those three things. And then we can move forward, I think.
So with that, thank you very much. Very quickly, Deloitte does need to get the lanyards back. Longwoods does that as well. We always have to collect the lanyards. They're expensive, and if you have a number of events ongoing, the expenses really grow up. So there'll be some people at the doors collecting them, but you can also just leave them on your chair. There are very few opportunities you're going to get this group all together at once. Feel free to network, get to know them, ask them your questions. Don't let them leave. Have a great day.